to share my knowledge with uh, my seniors and my colleagues, right, who are going to face to the AB exams. And these are very important occasions, right? Most of our people are going to face to some sort of EB exam. Sometimes you are doing your works in your laboratories uh, during few years, but some people maybe work in microbiology, some people maybe work in histology. Therefore, sometimes hematology area not uh, touched by our people, right, very recently. Therefore, sometimes when you go to face to the exams, or when you go to give some answers to the questions in EB, you have to refresh your knowledge. Therefore, I will try to do my best to share my knowledge with you all, right? Therefore, I kindly request your kind participation and the support for this purpose. Right. Okay. My objective in this discussion is, first, we are going to face to a EB exam, and we have to write some answers for essay questions or structured essay question. Most of the time that may be structured essay question paper, right? Then this is a model of that type of question. In this discussion, my main objective is to give some knowledge, to share some knowledge, to give the answers for the hematology questions related with the leukemia mainly. The topic given to me was leukemia. Then I'm going to show you some very important areas to give the answers for these sort of questions, right? Then this is the model.
Recording
This
in
is the model of
progress.
a question, uh, right? That my main objective is that, as well as I like to share my knowledge uh, to improve your service, to improve your hematology works in your hematology laboratory. At the end of the session, uh, I will give the chance to discuss some general hematology things or matters, as well as the leukemia. Right. Now, when we go to this question, now I hope all of you can see this slide. Now try to give your answer yourself without saying. Now you can plan your answer for this type of questions, right? In this slide, I am not going to give the answers, just to show you how these questions are come, and you try to plan your answer yourself, right? At the end of the presentation, again, we will come to give the answers for this type of question. When I brief this question, a patient has a full blood count report with total WBC 50,000 per liter, and write down 3 possible errors that can be occurred in the process of automatic full blood count analyzer, right? The blood picture of the above sample showed very high neutrophil count with left shift, and they ask name 2 probable clinical condition. Then you have to give 2 probable clinical condition for this high WBC count. And they say that very high neutrophil count with left shift is present in this blood picture, right? Then third question they ask, list 4 blood morphological features. List 4 blood morphological features supports to differentiate about 2 clinical conditions. 8 marks are there, right? Then you have to plan your answer for this question. Write on sample collection for coagulation studies, that is general hematology. Then here, another question is there. You have to describe the blood film appearance on iron deficiency anemia, infectious mononucleosis, and chronic granulocytic leukemia. According to my topic, right, then you have to describe the blood film appearance of chronic granulocytic leukemia here, right? Then you try to plan your answer, right, during this presentation, right? When we start this, right, what is hemopoiesis? What is hemopoiesis? Hemopoiesis is the process by which all types of blood cells are formed from stem cells, as we all know. We already learned hematology. Then we know that hemopoiesis starting in the bone marrow, right? And what are the sites of hematopoiesis? Next question is, what are the sites of hematopoiesis? Now you try to uh, plan your answer, right? Name third one, name three myeloid precursor cells that can be seen in blood picture. Okay. First question, the answer is the process by which all types of blood cells are formed from stem cells. That process we called as hematopoiesis. Okay. Second one is, what are the sites of hematopoiesis? Now, when we consider about the sites of hematopoiesis, mainly there are three sites we should know: yolk sac, liver and spleen, and the bone marrow. In different hematopoietic
Recording in
stem cell,
progress.
and it develops in by using main two pathways, right? Common myeloid progenitor cells. You can see, I hope you can see my cursor point. Common myeloid progenitor cells, which leads to produce our granulocytes, right? And common lymphoid progenitor cells, which leads to produce lymphocytes, right? There are main two lymphocytes as we know, B lymphocytes and T lymphocytes. Then they starting from common lymphoid progenitor, which starting from multipotential hematopoietic stem cell in the bone marrow, right? Then when consider about the common myeloid progenitor, our main three line of cells, three cell lines are produced from this common myeloid progenitor, mainly, right? When you consider the WBC, white blood cells, it's starting from the myeloblasts. Then main three mature white blood cells we know, neutrophils, eosinophils, basophils, as well as our monocytes are origin from common myeloid progenitor. Then I will mention a very important point here at the end of this slide, right? Just remember monocyte also starting from common myeloid progenitor. Then erythrocytes also producing from the common myeloid progenitor, and megakaryocytes, which leads to produce thrombocytes. So the platelets are starting from common myeloid progenitor. Okay, usually we know, we already learned theory. Then this is for a revise, right? Now, what I need to say is monocyte, right? Most of the people who have the experience with the blood picture screening or the manual WBC screening, when you observe the blood film through the microscope, sometimes, right, you can see monocytes with some small granules. Actually, we consider the monocyte as agranulocyte, but some blood films we can see monocytes with hypogranulation with few amounts of granules. That is because of actually these monocytes coming from or origin from common myeloid progenitor. That's why you can see sometimes few granules in your monocytes. Okay, this is the main hemophysis pathway. Now this is for revise. I'm not going to discuss the cell morphology in details in this moment, right? When we go through this discussion, again, I will come back to these slides to discuss more details. Before that, I need to just show what is the pathway of myeloid precursor cells, or what is the pathway of maturation of myeloid cells, right? Now it's starting from the, as previously I told, the common myeloid progenitor cell. Then it developed up to the myeloblast. Then it developed up to the promyelocyte. Next stage. Next slide stage is myelocyte. Then from the myelocyte, actually, the cells are dividing into three categories according to the uh, color or the philicity of, or the color of the granules. As myelocytes divide into three main two categories: eosinophilic myelocytes and neutrophilic myelocytes. Now, I'm not going to tell more details about now, right? Then after the myelocytes, it developed up to the metamyelocytes, then band form, then it developed up to the segmented neutrophil, as well as then eosinophil and basophil, right? Then here also you can see a promyelocyte. We will come back to the slides again, right? Now, according to the topic, our topic, I need to discuss about the leukemia, right? What is acute leukemia, right? There may be a question in your structured essay paper. What is acute leukemia, right? Then you have to say, you have to give your description. Acute leukemia is rapidly progressing cancer. That's a rapidly progressing cancer of blood and bone marrow characterized by uncontrolled growth of immature white blood cells. That is rapidly progressing cancer, and that is characterized by uncontrolled growth of immature white blood cells. That is because of maturation arrested due to a mutation. That may be due to a mutation. Your maturation of white blood cells arrested. Arrested means stopped. As a result of that, just think, if your peripheral blood doesn't have mature cells to do the immunity or to do the other normal functions, your peripheral blood demand for mature cells is increased. As a result of that, your bone marrow start to produce more and more cells. Then as a result of that, uncontrolled growth of immature cells will be occur in your bone marrow. Because of the cancer now, because of the leukemia, your maturation arrested. As a result of that, your bone marrow totally filling with. That means bone marrow totally packing with immature white blood cells. Then what happens? When your blast cells count is more than 20% in your bone marrow, we categorize it under the acute leukemia. Then again, what is acute leukemia is rapidly progressing cancer of blood and bone marrow characterized by uncontrolled growth of immature white blood cells. In your answer, there should be rapidly progressing cancer and uncontrolled growth of immature white blood cells, and it is more than 20, it should be more than 20% of blast cells should present in peripheral blood and bone marrow. That is what acute leukemia, right? When we consider about the chronic leukemia, leukemia can be divided into two phases, as we know: acute leukemia, chronic leukemia. Then what is chronic leukemia? Slow growing cancer of blood and bone marrow in which abnormal white blood cells build up over time. That's a slow growing cancer in blood and bone marrow, and abnormal white blood cells build up over time. That takes sort of time to develop this cancer, and your blast percentage is less than 20% in peripheral blood and bone marrow. That is the remarkable, that should be the remarkable point. Your blast percentage must be less than 20%. And I need to say another very important thing. There are some cases, in some cases, when we go through the bone marrow smear, we can see the blast percentage is 15%. Then then there is a problem. Why? Now that blast percentage is 15% in your bone marrow. Usually you can categorize it under the chronic leukemia, but in diagnosis purpose, right, we consider that bone marrow is in accelerated phase in chronic leukemia. That bone marrow is in accelerated phase because that blast percentage is somewhat closer to 20 now. That can exceed the limit of 20%. That can overcome, that can go above the 20% threshold. That means that your chronic leukemia may be converted into the accelerated into the acute leukemia. Therefore, when your bone marrow, when your blood smear or bone marrow smear having 15% of blast cells, we can categorize it under slow growing cancer and abnormal white blood cells built up over time, and blast percentage is less than 20, right? Okay. Then what are the types of leukemia, right? As we know, this is actually, these are very simple things to the hematology people who are doing the work in hematology sections, but we have to discuss because some people doesn't have the touch in this moment, right? What are the types of leukemia? Then leukemia, as we told previously, mainly divide into two categories as acute leukemia and chronic leukemia. Now you can give definition for this acute leukemia and chronic leukemia as previously we discussed. Then acute leukemia, we divide into another two category as acute myeloid leukemia and acute lymphoblastic leukemia. Acute myeloid leukemia, next one, acute lymphoblastic leukemia, AML and AM. Then chronic leukemia also divided into two categories, chronic myeloid leukemia and chronic lymphocytic leukemia. Chronic myeloid leukemia or chronic granulocytic leukemia, another name, and next one, chronic lymphocytic leukemia. Okay, now we are going to discuss these main classified categories one by one, right? There may be a question, what is the classification? What are the types of acute leukemia, or write the types of acute leukemia, or write the types of leukemia that you can find in your that present in this disease. So there may be a question like, what are the types of acute leukemia? Then you can give the answer very simply because of the structured essay papers you will be receiving, right? Okay. Now this slides having a lot of informations that is nice to know, but in your purpose, right? Then you can extract some very important points from these. That's why I put this slide here. Now I'm going to discuss some details about the acute myeloid leukemia. As we know, acute leukemia, previously I told, consists of a maturation arrest. Maturation arrest means maturation stopped or disturbed in the bone marrow cells. That's why immature cells proliferate inside the bone marrow. Actually, that is the cancer, right? There are several factors have been implicated in this AML, right? Causative factors. Mainly, there is a one important factor, myelodysplastic syndrome, right? Those are antecedent hematological disorders, myelodysplastic syndrome, and they are one causative agent, environmental exposure, that may be radiation exposure, or that may be chemical exposure, and drugs exposure. However, most of patients having this acute leukemia, acute myeloid leukemia, unfortunately, no identifiable risk factor, right? Then diagnosed by presence of more than 20% blasts in the bone marrow, and uh, however, recently on WHO classification, acute leukemia may be diagnosed without the expected 20% blast in the presence of described genetic changes. I will discuss, right? There are, when we consider about the classification of this acute myeloid leukemia, previously we learned about a classification called FAB classification, French American British classification, FAB classification. But now that is somewhat outdated, but still we using for this diagnosing purposes and treatment purposes. Now WHO classification is using for these diagnosing purposes and to the treatment purposes by using genetic, or by observing, by investigating genetic mutations, right? I will briefly discuss in future. Okay, then bone marrow infiltration by abnormal blast, production of normal blood cells markedly decreased, resulting varying degrees of anemia, thrombocytopenia, neutropenia. Anemia means we know low hemoglobin, right? Thrombocytopenia, low platelet. Then neutropenia, neutrophil count is low, right? Then later the blast cells spill out into the peripheral blood. That's why it happens, right? Now, usually we know as people who main stakeholders, we doing that full blood count actually, right? We already observed some cases of this acute myeloid leukemia. Then we know that usually WBC count increase in this case. And if you have the experience, we know that hemoglobin amount or the hemoglobin reduces and platelet count also reduces. That is the usual figure of the full blood count report. But sometimes, right, if you have the experience, we can see some full blood count reports with pancytopenia. Pancytopenia means WBC count low, hemoglobin low, and the platelet counts low. If you're having a blood report, full blood count report with pancytopenia, sometimes if the patient's presents with this figure, right, continuously, then consultants are usually focusing for a bone marrow aspiration. Why? This pancytopenia feature may be due to a origin of acute leukemia inside the bone marrow. What happens there actually? If your bone marrow is packing with the immature cells, as I previously told, mature cells will not produce and spill into the bone marrow, spill into the peripheral blood. That is why that indications comes to us, right? The white bloods, mature white blood cells, red blood cells and platelets are reducing in the peripheral smear. That's why we have to observe the bone marrow at that time. With the experience we know, when the patient undergoes for the bone marrow aspiration, right? That time your bone marrow totally hypercellular and packed with white blood cells, immature cells, white blood immature cells, because of these already started the proliferation of white blood cells in your bone marrow. That's why your peripheral blood smear shows some low counts. Therefore, as a gold standard, we can't take, right, each and every patients which are exposure to the leukemia, right, should not show a blood full blood count report with high, always high WBC count, right? That's what I need to mention here, right? Clinical features are, I'm talking about the acute myeloid leukemia that will present in the young adult and middle-aged people, bone pain, joint pain, fever, then easy bruising and bleeding, such as bleeding gums, right? Skin bleeding, nose bleeding, abnormal periods, and feeling weak or tired, right? Infections, continuous infections, right? Loss of appetite and weight loss, then pallor, right? Lymphadenopathy, right? Hepatosplenomegaly, right? Disseminated intravascular coagulation or DIC, right? Sometimes because of acute myeloid leukemia, AML M3V, right? Your coagulation factors will be hyperactive and it will form some, it will produce, it will leads to process of coagulation, and it leads to uh, it leads to produce that disseminated intravascular coagulation in your blood. Then that's also a clinical feature in AML, right? When you consider about the diagnosis, there may be a question, write laboratory test. Very simply, there may be a question, write laboratory test that you used in your laboratory to diagnose AML. Then these are the diagnosis process, right? You have to do the full blood count first. Then usually we know WBC can be increased, normal or decreased. That's why I told. If your bone marrow started to proliferate, if your bone marrow totally packed with the immature cells at that time, you will be receive a normal full blood count report or a decreased amount of WBC in your full blood count report. If that happens continuously, definitely you should focus on your bone marrow, right? Then next one is anemia, hemoglobin will become low, thrombocytopenia, those are full blood count indications. Then you have to do a blood picture, then bone marrow aspiration and biopsy, that's the next step. Then parallelly, they will do imaginations, ultrasound scan in the abdomen. Then parallelly, they will do lumbar puncture, spinal tap to check for the leukemic cells in the spinal fluid. Because with your bone marrow packing, sometimes these blast cells will be spill into your cerebrospinal fluid, right? Then bone marrow aspiration and biopsy, that is definitive for confirming leukemia. For bone marrow aspiration, right? We can do Romanowski stain first, then we can use special stains, right? The next step is immunohistochemistry. Immunohistochemistry. That's mean in bone marrow aspiration, we usually taking refined biopsy. Then refined biopsy will be sent into the histopathology laboratory to the processing. Then after the HNE staining, then we have usually they go through the refined biopsy or the cells in the refined biopsy. Then next step is flow cytometry to confirm for the types of leukemia, and cytogenetics. In cytogenetics, they do we have to do some special investigations for diagnosing acute myeloid leukemia, mainly BCR-ABL, one example, another one PML RARA, right? Then translocation panels, lot of cytogenetic testing or the investigations nowadays they use in the treatment for the diagnosing purposes, right? Then PCR, polymerase chain reaction, and gene expression profiling. These are the main diagnosing profile. This is the main diagnosis profile for acute myeloid leukemia. Right. Now, I need to refresh your knowledge about some abnormal cells, because sometimes there may be a question in your uh, paper, list 4 or 3 morphological features in blast cells or in immature cells that you can see in your blood picture in AML cases like that. List 3 features of your myeloid precursor cells that you can see in acute myeloid leukemia like that. There may be a question. That's why I need to, then that time you can just write 3 points of that abnormal cells, or you can just draw by using the pencils and you can just mark the features. However, by using any technique, you have to show your knowledge about that abnormal cell. That's why they are assessing that. That's why they putting that type of questions, right? Actually, when you go through the past papers, you can see that type of questions, right? Therefore, first, I'm talking about the acute myeloid leukemia. In acute myeloid leukemia, you can see myeloblast in your blood smear, right? For as a revision, right? For refresh your knowledge, now I will tell some features of this cell. Now you can see some abnormal cells here. First thing is, right, you should identify these cells as abnormal cells. These are not normal or mature cells because these cells are large. And when you consider about the nuclear cytoplasm NC ratio that is high, that's mean nucleus is spreading in the cell more than 90% actually, most of the time, right? That may be changed, right? But however, more than 90% of the cell is nucleus. And that nucleus having loosely arranged chromatin. Now here you can see this chromatin color is very pale than the mature cells. When you consider about a mature lymphocyte, cell is smaller than this one, and the nucleus is darkly stained and chromatin are condensed there. But here you can see loosely arranged chromatin, NC ratio is high, and you can see some nucleoli here, right? The very pale area, those are called as nucleoli in this. Now, I hope you can see in this picture. In this cell, you can see nucleoli. Now, if you're having these features, right? NC ratio is high, loosely arranged chromatin, and nucleoli present, and in the cytoplasm, you don't have any granules, then this cell is categorized under the blast. Actually, directly we can't say these are myeloblasts without using any other cytochemical staining or any other next level technique. But with the experience, people can say, people can guess this as a myeloblast. But if you observe a very important feature in the cytoplasm, right? I will discuss in later, right? If you observe that feature directly, you can say, you can categorize the cell under the myeloblast. I will discuss that later, right? But however, you should think about this cell. Cell is large, nuclear cytoplasm ratio, NC ratio is high, and nuclear having some loosely arranged chromatin, nucleoli present. Then if you have this profile, we consider this as a blast. And by using cytochemical stain or by using very next level identification techniques, you can say it as myeloblast. I will discuss, right? Okay, now here also you can see some myeloblast in this picture, which you can see in your AML blood picture, right? Now this is the feature I need to say. Now you can see in these myeloblast or these blast, in the cytoplasm you can see these types of magenta color rods. We call those as our rods. If you can identify our rods in your blast cell, yes, now you can say, you can categorize that blast cell under the myeloblast, right? Right. Now here you can see our rods in your myeloblast again. And special thing I need to say, now we are using very developed, right, full blood count analysis. There are some analyzers that using dye binding techniques and laser scattering techniques for do the differential count or give the differential count, right? We can discuss a lot of details about those now, about those techniques, but I am not going to discuss more details here. But just I need to say, when you consider about the scattergram of this modern analyzers, which we use the dye binding technique, when I brief that, that analyzer give the differential count by using the scatter plot diagram, and the area of this scatter plot diagram. The technique is in the laser scattering technique, right? Then this dye which we use in these analyzers goes and bind with the DNA and RNA of the white blood cell. Then it when it goes to the cells, goes to the laser beam, right? It illuminates some illumination, so it gives some fluorescent signal. With these fluorescent signals and forward scattering and side scattering signals, some plots you can see in your scattergram. Then by using those plots, right, according to the area of the plots, right, this analyzer gives you the differential count. That is briefly what the technique, right? But I need to mention here, when your blood having some myeloblast, you can see in this scattergram, right? This neutrophil, this is the neutrophil area of this scattergram. That neutrophil area flamed. Flamed means dispersed to the fluorescent side axis. There is there now when you observe this scattergram, this abnormal scattergram. If you're having this area, yes, this is a very important evidence. Your blood may having some abnormal cells, abnormal myeloid precursors, right? That's what I need to mention here, right? Okay, now this is a one case study, right? Now when you go through this full blood count, now you can see WBC count is 87,000 and HB is 7.2, platelet is 40, right? Then absolutely this will give a indication. We have to do a manual differential count for this manual DC, right? When we observe this slide, we already can observe some blast cells here, right? When you uh, in this case, they have done this DC, blast cells 80%, neutrophil 1, lymphocyte 1, eosinophil 1, and monocytoid cells came here. Monocytoid is another abnormal uh, immature cells that you can see in acute myeloid leukemia, AML, 5. But don't think about those things more and more. Just I need to say here, right? In this type of full blood count reports, right? If the analyzer gives these abnormal results for the monocytes or abnormal results for the lymphocytes, and uh, if you receiving some, if you're obtaining or receiving some abnormal scatter plot with the flames like this, definitely those are evidences for, right? You have to go through your manual differential count, and you have to observe the blood film for the abnormal cells, right? You have to observe the blood film for the abnormal cells, right? This is AML case, AML M5, right? Right? This is a case from Cancer Institute, right? Then here you can see some abnormal flags. There may be a question in your EB paper, right? What are the abnormal flags you can see in your modern full blood count analyzers? Then you have to, you should have little bit of knowledge about these abnormal flags. If your scatter plots showing some abnormal flames, that analyzer already fed with some abnormal flags. If the analyzer receiving some details or the data about the abnormal scatter values, that analyzer already giving some abnormal flags. As example, if your blood having immature granulocytes more than 40%, 40%, right? That is the threshold of the analyzer to give the flag. Then analyzer gives flags as abnormal lymphoid cells present or blast cells present or left shift, like with the query mark, this analyzer gives you an abnormal flag. That is because of the abnormal scatter plot, right? That's also very important to know. Okay. Now, traditional Fab classification of the AML, this already we learned from the schools as well as the universities, right? This is Fab classification. Then there are 7 types from M0 to M7, right? When I brief this, M0 undifferentiated leukemia, or you can see some undifferentiated blood cells in the bone marrow. Then M1 myeloblastic without differentiation. There are some, the major population is myeloblast, but no differentiation. M2 myeloblastic with differentiation. There are again major population is myeloblast. There are some differentiation and you can differentiate the cells as myeloblasts, right? M3 major populations are promyelocytes. We will discuss about the promyelocytes in details again, right? M4 myelomonocytic leukemia. You can see a lot of myelocytes as well as the monoblasts and monocytes in your blood smear, right? Then Next one, AML-M5, that is called as monoblastic leukemia. AML-M5 divided into two categories again, M5A and M5B. M5A mean monoblastic with differentiation. That means in blood smear you can see major population of monoblast with the monocytes, minor populations of monocytes and other mature cells, right? Then M5B, you can see major population of mature monocytes with minor population of monoblasts, right? That is M5B. Then M6, erythroid leukemia. In that case, you can see erythroblast in your bone marrow as well as the mainly in bone marrow, right? M7, megakaryoblast leukemia, and that time you can see a lot of megakaryoblast, which are the precursor cells of platelets, right, in the bone marrow. Then that time your peripheral blood smear shows increase platelet count. Now there is a point to capture. When your full blood count shows a result of high platelet count, more than sometimes that may be more than 900,000, then you have to go through the blood smear to observe is this the actual platelet count. If you having that type of indication, definitely that patient will be undergone with the bone marrow for the abnormal proliferation or the myeloproliferative disorder that related with the to screen the myeloproliferative disorder that related with the megakardioblastic leukemia or thrombocytosis, right? Therefore, sometimes that may be due to the megakardioblastic leukemia. All right. Then this is the traditional FAB classification. Then I will I will show a very nice brief about this AML classification. Now here you can see AML M naught. As I told, morphology blast, undifferentiated blast are there. Then when you go to the cytochemistry, that's mean the special staining techniques, right? AML M naught, that's mean having myeloblast, right? Then usually myeloblast uh, shows with Sudan black positivity or Sudan black positive, Sudan black when you do the Sudan black staining, right? Myeloblast will become positive while the lymphoblast negative. We will discuss it, right? Then in here you can see some cytochemical markers are there. MPO means myeloproliferate, uh, myeloperoxidase and NSC, then PAS, all are negative. Then here myeloid markers will be positive, CD13, CD33 positive in flow cytometry, like that, right? These are not definitely. I hope these will not come to your EB, but for your knowledge, right? You can see very nicely AML classified for 7 types, and that will show different types of positivity in cytochemistry as well as the flow cytometry, right? Then different CD markers will be positive in these different cases. That's why in flow cytometry, you can categorize, you can classify these, you can type these AML as AML M1, M2, M3, as so on, right? Then that is what I need to say here, right? That is traditional classification of AML. This is the newer classification or the WHO classification. Nowadays, they are using AML with recurrent genetic abnormalities, AML with multilineage dysplasia, AML and MDS therapy related leukemia, then AML not otherwise classified. Like that, according to the genetical mutations, and by using the genetical translocations, they just classify this leukemia into these categories. In IEB, they will, I hope, uh, they will not ask about these classifications and what are the types and what are the examples like that. But however, to know there are 2 types of classification. No? Then this newer classification is the WHO classification that used by using cytogenetic translocations, right? Right. Next question. Write some examples for special stains that used to identify and differentiate the types of blast cells in leukemia. Right. Okay. Write some example for special stains. As previously I told, now you already know about your blast. Now you can identify the blast. But you don't know what is the type of blast. Then next step is to identify the type of blast. Now if the patient is suffering with AML or acute myeloid leukemia, the blast should be myeloblast. If the patient is suffering with ALL or acute lymphoblastic leukemia, blast should be lymphoblast. Then you can differentiate this type of blood by using some type of special stains, right? There may be a question, what are the types of special stains or types of special stains that can use in your laboratory to differentiate the blast cells? Then our answer is Sudan black bee stain you can do to differentiate these myeloblasts, because myeloblasts having lipids in the cytoplasm. Then by using the Sudan black bee stain, we can stain these lipids in by lipids. Then that lipids will be stained with black color. Then you can see black color cytoplasm after this stain. You can nicely differentiate your blast cells or the cytoplasm of your blast cells totally stained with the black color. Then we consider that as Sudan black B positivity or the Sudan black B positive blast. If your blast cells are positive with the Sudan black stain, those are myeloblasts. And parallelly, we do uh, another staining for the same case, that is PAS or PAS stain, periodic acid shift stain, because your blast may be lymphoblast. Therefore, by using only the Sudan black stain, you can't tell, you can't identify that as a lymphoblast. Therefore, parallelly, you have to do Sudan black stain as well as the PAS stain for the same case. If your if your bone marrow having lymphoblast, your PAS stain will become positive, right? Uh, there are some characteristic features you should identify in your Sudan PA stain technique, right? We called it as block positivity. I will show you with the next slides, right? However, then Sudan, if your Sudan black be positive, if your Sudan black be stain positive, right, we can identify that blast as myeloblast, and your PA stain will be negative for that type of blast. Then another one is myeloperoxidase, MPO staining. The same you can use to identify the myeloblast, except of the Sudan staining, you can use MPO staining. Then that will become positive for the myeloblast, right? Then, as previously I told, PA stain that also used to identify the type of blast, right? Your PA stain will become positive for the lymphoblast, and lymphoblast cytoplasm will show you some, oh, that you can identify some magenta color blocks in the cytoplasm in this staining technique, right? If your blast shows block positivity, that says PA is positive. PA is positive mean that smear having lymphoblast, right? Then next one is NSE. NSE mean non-specific esterase. This non-specific esterase test is used to identify monoblast. If the patient is suffering with AML M5A or M5B, right, that means major populations are more major population is monoblast there, right? Then you can identify these monoblast by using this cytochemical staining technique, right? Actually, previously in past in Cancer Institute and other institutes, mainly in Cancer Institute, we already used the 10SC stain to identify these, to give evidences for the identification, whether it is monoblast or whether it is myeloblast, whether it is lymphoblast. We already use these stain techniques, right? Then NSE is used for identify monoblast, right? Non-specific esterase test, right? Next one, dual esterase staining technique that is used to identify. You can differentiate, right? Monoblast as well as myelocyte, which present in the same smear in the case of AML-M4. Myelomonocytic leukemia. In myelomonocytic leukemia, you can see monoblast, monocyte, as well as myelocytes in the bone marrow smear. Then you can differentiate, you can identify these monoblast as well as the myelocytes in the smear, right, in the same smear by using this dual esterase technique. Right? Now here you can see this Sudan black bee stain. Why I'm discussing these things? There may be a question. Write down some special staining techniques you used in identification of acute myeloid leukemia, and give the examples for the blast types that gives the positivity or negativity. Like that, there may be a question, right? Then Sudan black bee stain. This is the Sudan black bee stain. Now you can see there is a very nice blast positivity in this case. Now I hope you can see my cursor point here, right? Then this is the blast positivity. You can see this cytoplasm, black color cytoplasm you can see in this blast. Then we call this as Sudan black B positive smear, right? Therefore, definitely we can say these are myeloblasts, right? Then, as previously I told, this is the MPO staining technique or myeloperoxidase, and these are some positive MPO blasts, right? If your MPO staining gives this brown color cytoplasm, right, or black brown color cytoplasm, then we call it as MPO positive, or then your blast will be maybe myeloblast, right? Then this is stained smear. Now, as previously I told, you can see some blast there, right? Blast present, the smear having some blast with block positivity. Now, these called as block positivity. Here you can see magenta color blocks. After the staining technique, you can nicely identify these magenta color blocks as a, especially this is like a necklace, right? And magenta color blocks are present here. Then definitely this is PAS positive, and you can say this is lymphoblast, right? But here, can you see this cell? In this cell, you can't see any blocks, but you can identify some, granules, magenta color granules. We call this as granular positivity, but this is not the PS positive case, right? This is granular positivity. Granular positivity not considered as PS positive cells, right? Therefore, you should have magenta color blocks or the block positivity in the PS staining technique to consider that as lymphoblast. All right. Okay. Now here you can see non-specific esterase technique, NSC, as I told previously. Right? Those are monoblast. All right.
ඉස්සරු ඇහුන් නෑ ටිකක් එතන.
Right. දැන් ඇහෙනවද?
Yes, now previous slide, I think.
Right. This slide, this one?
Yes.
Right. Okay, then I will repeat it again, right? I told about the PA stain here, periodic acid stain technique, right? Staining technique. Once after you did your staining technique and once you observe your smear, you can identify some blast cells with block positivity. Block positivity means you can see some magenta color blocks in your cytoplasm. I hope you can see my cursor point, right? Then here you can see some magenta color blocks in your cytoplasm, right? Then this is called as block positivity and PAS positive blast, right? And there may be some cases, there may be some cells which having some granules or magenta color granules, right? You don't have any blocks there, right? You just magenta color granules you can observe. That is called granular positivity, but that is not, we not considering it as PAS positive cell. What I need to say is, if you categorize or if you diagnose it as a PAS positive smear, definitely there should be, right, magenta color blocks, right? Then that is called block positive. Right. If you're having some PAS positive blast in your smear, right? Called it as lymphoblast. Then you can nicely identify ALL, or you can have evidence. You can identify it as a lymphoblast. It has a lymphoblastic leukemia, right? Okay. Let's move to the non-specific esterase, NSC, right? Here you can see some cells with brown color cytoplasm. Then after the non-specific technique, you can identify this in your smear. Then these brown color cells are monoblast. In AML M5, right? AML M5A and M5B, as I previously told, right? Then you can see monoblast in your bone marrow smear or the blood smear. Then by using non-specific esterase test, right, you can demonstrate these blast as monoblast. You can identify it as monoblast. That's evidence for the further identification for the AML M5, right? Then this is a non-specific esterase test. In briefly, you can use NSC for identify, differentiate monoblasts, right? That is what you have to know, right? Then this is dual esterase technique, right? By using this dual esterase technique, you can demonstrate, right, monoblast as well as myelocytes and myeloid precursor in your blood smear, right? In AML M4, right, myelomonocytic leukemia, you having monoblast as well as myeloblast and myelocytes in your blood smear. You can very nicely demonstrate both type of cells in the same smear by using this dual X-rays technique. Now here you can see this bluish color cytoplasm and brown color cytoplasm. Then bluish color cytoplasm monoblast will show you this bluish color cytoplasm. Then myelocytes and myeloblast uh, you can identify as brown color cells here. Then by using this, if you are having some experience with the dual SRS, definitely you can say this is a case of uh, AML myelomonocytic series. So this may be a myelomonocytic leukemia. By using flow cytometry, you can confirm that, right? Okay. Then these are the special staining techniques that you can use in your laboratories, right? Okay, then these are to for your further knowledge. In management, they start the chemotherapy. There are different stages in that chemotherapy. We call this the induction therapy, consolidation therapy, and maintenance. Right? Actually, I'm not going to discuss in details. Just to know, right? Chemotherapy will be start. Then there are different types stages in that chemotherapy. Right? Okay, this is a very important case. Why I put this here for this discussion to motivate this our colleagues actually, as all then we already doing our techniques, so we are the people mainly do the investigations. We actually we are the root of the diagnosis process. Therefore, we have to do these type of things. This one of our junior brother, right? He already did he have some experience, a few year experience in Apeksha Hospital, and after the his transfer, right? He transferred to this Mavadala the divisional hospital. Then he gave me a call one day, right? Uh, I already received the blood. Actually, I having a just three-part analyzer, but uh, platelet is low. Therefore, I drew the smear. Then I observed the smear. I can identify some abnormal cells are there. Then I asked him to send some WhatsApp photos. Then when I go to the blood picture, definitely those are blasts. Then I ask him to, Mali, you do the blast cell count because you have enough experience to do to that. Then he very nicely, directly he did the differential count and he counted the blast cells. Right now, as here you can see, he counted the blast cells, blast 39%, and very nicely he suggested, right? Suggested directly, he suggested this may be AML and suggested blood picture, right? Then that confident we should have. Then patient rapidly transferred to, as I know, that patient was transferred to the Mahamodara hospital. Then after that, sent to the Cancer Institute, the Maharagama Apeksha Hospital. Then finally diagnosed as AML case. You see, from divisional hospital, because patient came to do a full blood count for her pregnancy. Only for that. Patient is in the pregnancy period. I was in the pregnancy period, then just came to do a full blood count. Then our person very nicely captured her, and finally he played the major role to save her life. Right. That is what I need to say. In this type of cases, right? We are the people. We should have enough confidence to identify these type of cells. If you have the continuous practice and the improvement, continuous practice, continuous observations, right? You should have the fever to follow these cases, right? Then you can save the life. Actually, that may be a very important uh, step that you do a person's life, right? Right. That's why I need to put this type of case. Right. Then acute lymphoblastic leukemia. We already learned about acute myeloblastic AML or acute myeloblastic leukemia. Then I will discuss about the acute lymphoblastic leukemia. Then this mainly acute lymphoblastic leukemia affects to children age between 3 and 7 years and may also occurs in adult. Symptoms: anemia, thrombocytopenia, neutropenia, which is similar to AML, right? Then bone pain, fever, hepatosplenomegaly. Those features are common for acute AML as well as the to the acute lymphoblastic leukemia. The features are common, symptoms are common, right? Then diagnosis. The same diagnosis route we have to follow, or the things in diagnosis route we have to do peripheral full blood count, then blood picture as AML. The peripheral blast count may be more than 20% here, because that is categorized, that is also categorizing under the acute leukemia, right? Then we have to do the bone marrow aspirate as well as the refined biopsy. Then bone marrow, as for the bone marrow aspirate, we should do the Romanowski stain for the morphological screening, then special staining as well. Previously I told, then flow cytometry and genetical studies. These in diagnosis we have the common diagnosis route for the both type of leukemias, right? AML and ALL. Right. When you consider about the Fab classifications of the ALL, acute lymphoblastic leukemia, previously we learned as ALL L1, L2, and L3. Right. ALL L1 is small, then that is that having small uniform lymphoblast in your blood smear. Right. ALL2 having large variable lymphoblastic in your blood smear. ALL3 you will receive, or you will observe some large basophilic lymphoblast with vacuoles. That is called as Burkitt type. That is why we called as this ALL3 usually we consider as Burkitt cell lymphoma, right? That's because of Burkitt cells. You can see Burkitt cells mean those also type of lymphoblast with vacuoles in the cytoplasm, right? In WHO classification, nowadays we using this acute lymphoblastic leukemia divided into two categories as B type of acute lymphoblastic leukemia, BALL and TALL. BALL is more common in children and TALL is more common in adolescents, right? Okay, right. There may be a question, right? Now, what are the types of acute lymph or ALL? What are the types of ALL, right? According to the WHO classification. I don't know. There may be a question, right? However, then you should know WHO in WHO classification BALL. We classify ALL into two categories, BALL and TALL. Right. Now here you can see this blood picture. Now I am sure you already now have a experience, or you already refreshed your knowledge now to identify blast cells. Therefore now I am sure you can identify these, those are as blast cells, those are not lymphocytes, these are not lymphocytes, these are blast cells. Again, to revise, I can tell these criterias. NC ratio is high, right? Then you have some loosely arranged chromatin, uh, loosely arranged chromatin in the nucleus, and sometimes you can identify nucleoli present in this nucleus. When you go to this cell, you can see nucleoli. You can identify the nucleoli, right? Uh, Once you observe very carefully my cursor point, these are nucleoli, and these cells are lymphoblast. These cells are lymphoblast, but you can't directly say this as lymphoblast. If you have a very good experience, you can say this as lymphoblast because entire margin is there and equal uniform size is there, and you don't have any overrods there. Then your nuclear margin also entire like that. If you have the enough experience, you can categorize it under the lymphoblast, right? But however, that is with the experience, no. But to classify this as lymphoblast, you have to do Sudan black stain as well as the PA stain. Then now what you say? Now what you can say? Sudan black stain, Sudan. In this case, if these are lymphoblasts, your Sudan will be negative and your PA stain will be positive, right? Sudan negative, PA is positive. Those blasts categorized under the lymphoblast, right? Okay. Then now this is the scattergram. This is the scatter plot, right? You can observe in this scatter plot will be in your full blood count report. Now you can see lymphocytic region. This region is lymphocytic region, and lymphocytic region is flamed to fluorescein area or spreaded to the fluorescein area, and this analyzer cannot differentiate the lymphocytic region. That's why it gives a white color and this spreaded or flamed upwards, and lot of area is condensed A lot of scatters are there like that. This is abnormal flame. Therefore, this also one evidence, right? You have to go through a blood smear because your scatter plot also showing some abnormal area, right? Okay, these are lymphoblasts. Okay, then I told previously mentioned about the types of ALL, right? ALL, L1, L2, L3. Now here you can see the three types, right? Uh, this is ALL L1 and this is L2 and this is L3 actually. This is to these are to your knowledge actually. Just only thing is you should have the idea here, right? These are blast cells. In acute lymphoblastic leukemia, you will you can observe lymphoblast in your blood smear. You can identify lymphoblasts by using special stains such as Sudan black and PAs. In lymphoblasts, Sudan black negative, PAs positive, right? Those are the brief points you should know to give a answer for structured disease type of question, right? Okay, when you consider about the management again, these are some more details. Induction therapy, consolidation therapy, and maintenance chemotherapy will give. Then allogenic transplantation. Now, this is the trend of the treatment now, right? Transplantation, right? Uh, those are the details about the management, right? I move to chronic granulocytic leukemia. This is CGL, or another name for that is CML, right? Occurs in middle age, 40 to 60 years people, right? Incidentally found high WBC, symptoms related to hypermetabolism, that's mean weight loss, then anorexia, night sweat, right? Splenomegaly, hepatomegaly, anemia, thrombocytopenia later, and this can transform into the acute leukemia. That is the problem here, right? If the patient is suffering with the chronic granulocytic or chronic myeloid leukemia, if patient is not identified quickly, right, gradually that can be transferred into the acute leukemia. That's why this identification process is very important, right? If you have the enough knowledge, if you have the enough experience, if you have the fever, even you don't have the experience, you can capture, you can identify, you can diagnose early, right? These patients, especially CML patients, if you can identify these patients early, you can save the life for more years, right? Right. Then investigations are again full blood count. In full blood count, you can see very high white blood cell count, neutrophilia, basophilia, eosinophilia, and thrombocytosis, right? Then blood picture, you can see peaks in mature neutrophils and myelocytes. Not only that, you will observe, you can see full spectrum of myeloid precursor cells. I will discuss it, right? Then NAPSCO is low, right? Then PH chromosome or Philadelphia chromosome studies, then PH chromosome will be positive, right? These are the investigations that we used in diagnosing AML, sorry, CML, chronic myeloid leukemia. There may be a question, what are the investigations that we use to identify the chronic myeloid leukemia or CML? You should write the answers, right? Investigations are these investigations, right? Then this is a case of CML. Now you can see the white blood cell or WBC count is high. That is 43,000.6, right? 43,000 and 43,000. Then hemoglobin 10.6, right? Platelet 353,000. And when you go through the blood picture, we already observed seven blast cells, promyelocytes 2, myelocytes 4, neutrophil, lymphocytes, basophils, as well as NRBC. Very important feature, NRBC. Right? If the patient, if your blood picture, even though your blood picture shows some less amount of bloods, less than 20%, less than 10%, and when you observing promyelocytes, myelocytes, neutrophils, lymphocytes, and basophils, and eosinophils, right? That may be an evidence for CML or chronic myeloid leukemia, but there must be, then you should observe your blood smear for a one important cell, that is NRBC. When you observe, when you screen, when you have enough knowledge about the CML, right? If you, even though you having this myeloid precursor cells, to confirm the CML to confirm the CML by using your blood picture, we can't confirm, but however, to have idea about the CML, you should carefully observe your blood picture for NRBC. If your blood picture shows NRBC, definitely that is the typical CML. If your blood picture or your blood smear not having NRBC, we called it as atypical CML. That is atypical CML, very rare case. But you must know, in your CML case, right, you will observe the full spectrum of these precursor cells, with NRBC. That is what I need to say here, right? And you will identify, you can see some abnormal scatter plot here again when you go to your full blood count report and the scatter plot. And now you can observe here this analyzer cannot differentiate the area. Just analyzer gives a abnormal scatter plot with the flame in each and every area, right? As usually, this is the lymphocytic area, then you don't have scatters there. Then this is monocytic area, that also don't having some more scatters. But in neutrophil region, you have a large scatter, undifferentiated scatters, and flamed scatters, dispersed scatters. That's mean analyzer cannot differentiate this neutrophil area. That's why it gives a abnormal scatter plot. Then this is a very important evidence to blood smear. Then when you go to the blood smear, before you go to the blood smear, you can have evidence. Definitely there may be some myeloid precursor cells if you have the knowledge about this scatter plot, right? Here you can see in this full blood count report, you can see there is abnormal scatter plot, right? Okay. Then this is another case from Kalubovila Hospital. Thank you, Peshini, to sending this. Then here, WBC count is 224,000, right? And your HB hemoglobin is 12 point, that is normal, 12.8. I previously told sometimes your HB hemoglobin and platelet may be normal here. Even the WBC count increase. Now here platelet count is low. Then they did their manual WBC differential count. Then they obtained these results. Right, blast cells 3%, then promyelocyte 10%, myelocyte 8, metamyelocyte 4, neutrophil 55, lymphocyte 8, eosinophil 2, monocytes 2, basophils 8, and normoblast percent. Now, this is the typical blood picture of the CML. There may be a question, what are the granulocytic precursors that can present in CML blood picture, right? Then you have to say blast cells, promyelocyte, myelocyte, metamyelocytes, then with the other mature cells, neutrophil, lymphocyte, eosinophils, monocytes, especially basophils, and granulocytic precursor cells are having granulocytic precursor cells present with the mature cells, as well as normoblast present in your blood picture. Then you have to say that. When you consider about the red blood cells, then amount of red blood cells may be low in the CML case. According to the case, you have to say if your hemoglobin and RBC count is low, definitely your blood picture shows some low amount of RBC and hypochromic cells, right? Hypochromic cells. Then if the question says write morphological features, so what are the precursor cells present in CML, you have to give the answer for that by using this knowledge. Okay, now I'm moving to the previous slide of granulocytic precursor cell. Now we are in the CML. That is why I need to write. Now these are the precursor cells that you can see in your CML blood picture, right? Now I am going to tell some details, more details about the myeloblast. Now this is a myeloblast. Now you can see high NC ratio here. Cell is larger, right? Then high NC ratio, and the nucleus having loosely arranged chromatin, as well as you can see, you can nicely observe a nucleoli here. In your microscope picture will be very clear than this because this is enlarged. However, you can see this area, right? You can observe that is the nucleoli. Then these are the features of myeloblast. NC ratio high, large cell, then loosely arranged chromatin, nucleoli present, but no granules in the cytoplasm. And scanty cytoplasm, scanty means very few area or the few amount of cytoplasm you can see in the cell. This is myeloblast. The next stage, as I told, promyelocyte. Actually, this picture is not well. Therefore, that's why I put this diagram, the right hand corner. You can see this cell. I hope you can see this. Dinesh, can you identify this? Can you see this clearly, Dinesh? Or any person, can you see this?
Yes, yes, sir.
Then, this is a promyelocyte. Then you can see nucleoli present in this nucleus. This is the nucleoli, and loosely arranged chromatin. NC ratio is somewhat high, and the only difference here is you can see granules present in the cytoplasm. Lot of granules, coarse granules present in the cytoplasm. This is actually as blast cells. You can just to uh, remember, you can remember it as a blast cells with granules, but that is totally wrong. You can't consider it as a blast, then that is a promyelocyte, right? But I need to say here, only difference than the blast is you can see some granules in the cytoplasm. You have high NC ratio, you have nucleoli in the cytoplasm, right? And nucleoli in the nucleus, and you can identify some nucleoli in the nucleus, and you can see, you can identify some granules, you can see some granules in the cytoplasm. Then those type of cells we called as promyelocytes, right? Then promyelocytes also you can see in your CML blood picture. Then next stage is myelocyte. In myelocyte, you can see nuclear indentation started. That means your nucleus is indenting to a one side, or that chromatin becoming dense with the maturation, and your nucleoli will be disappear. Therefore, in myelocyte, you can't see nucleoli. Then your NC ratio is somewhat lower than the blast, and cytoplasmic granulation you can see. Then your criteria, your profile is NC ratio is somewhat low, nucleoli absent, nuclear indentation started, and cytoplasmic granules you can see. Granules you can see in the cytoplasm, right? Then that those cells are we called as myelocytes. Then myelocytes mature, or the maturation will be continued up to the metamyelocyte. Then you can very nicely see nuclear indentations go further. More maturations will be taking place, and your cytoplasmic granulation will become fine, right? Then this cell is going to produce neutrophil actually, right? Then these type of cells we called as metamyelocyte. Then metamyelocyte mature further and further, and your nucleus will become band-like nucleus. Then that also a type of metamyelocyte, but we consider it as a band form. You can call it as band form, and horseshoe appearance also you can see. However, all those are coming under the categorized under the metamyelocyte. Then you can see the mature neutrophil next stage, right? Likewise, right, these eosinophils and basophils will be formed here. In your CML blood picture, you can identify blast cells that may be less than 10%, less than 20%, right? Or less than 10%. And you can identify, you can count some promyelocytes there, about 10, 12 promyelocytes, and you can obtain, you will be receive some myelocytes that may be about 25 30 like, just I am telling some figures to have idea. Then with the myelocytes you will be obtain some metamyelocytes, neutrophils, lymphocytes, and your eosinophil count also somewhat high, and basophil count is somewhat high, and you can identify some normal blast there. That is your CML typical blood picture. Now I think you got the idea, right? Okay. Then this is we are talking about CML now, right? This is your case. Then this is the blood picture of CML again, right? Blood picture of CML. Then you have some idea about these cells. These are myelocyte, and you have some band form here, right? And this picture you can identify some neutrophils as well as eosinophils, right? Then previously I told about the blood picture. Then in CML diagnosis route, right? After we observe the blood picture, if you have evidences about the CML, next very important technique, very important special technique, identification technique you can use. We called it as NAPSCO, right? Neutrophil alkaline phosphatase technique. That's a type of staining technique. You stain your blood smear by using the neutrophil alkaline phosphatase, or by using the reagents. Then you can stain. Then after the staining technique, we are the people, we have to do the NAPSCO, right? Scoring, right? You observe the neutrophil, and there is a technique to identify the neutrophil. If you have the experience, right, you can uh, identify the neutrophils with the blue color granules. Then that, according to the thickness, according to the intensity of the granules, we can give gradings for that neutrophils as +1, +2, +3, and +4. Then you have to count the categorize the neutrophil into those categories. How many neutrophils present in with +1 score, how many neutrophils with +2 score. Then you have to count the number of neutrophils with +3 score. Then finally you have to totalize the scores, and that is the NAP score. Then you can do that NAP score technique for as the identification technique in the CML. As we know, the your NAP score will be low or zero, right? When there is a case, right, looks like your blood picture looks like CML, but if that is not actually CML, there is a term we use called leukomoid reaction. I will discuss that, right? And that case, you can use this NAP score to differentiate that CML from the leukomoid reaction. In leukomoid reaction, your NAP score will be high. Okay, and I'm talking about the CML now. In CML, actually, the main cause for the CML disease is this 922 translocation or the mutation. Because of this 922 translocation, the name of that mutated chromosome is BCR-ABL chromosome. Because of this chromosome, your blood will secrete abnormal amount of tyrosine kinase enzyme. This is for your knowledge, actually. Then tyrosine kinase enzyme, because of the tyrosine kinase, your bone marrow abnormally start this proliferation and cause the CML because of this translocation or mutated chromosome. Then because of the mutated chromosome, tyrosine kinase secrete, then tyrosine kinase leads to produce the CML. In treatment purposes, what they do is they use some tyrosine kinase inhibitors as the treatment, as the chemotherapy. Then, as example, when we consider about the treatments, imatinib, that's a tyrosine kinase inhibitor. Then they inhibit Gleevec. Another name for that is Gleevec. You may familiar with that, right? Then that tyrosine kinase or Gleevec goes and inhibit the tyrosine kinase. Then that will control the unwanted abnormal proliferation of the bone marrow, right? That is why we have to do this quantification of and qualitative analysis of this BCR-ABL, or the usually we call it as pH chromosome analysis. That analysis we do by using a PCR technique, RT-PCR technique. Then that is called as pH chromosome analysis. Actually, in the treatment process and the monitoring process, nowadays they are using BCR-ABL investigations by just by using peripheral blood without doing bone marrow. That is very important to monitor the patient, and in the treatment process they quantify this, they observe this amount of BCR-ABL or the quantification test they do, and they adjust the Gleevec amount, Gleevec dosage to the patient. Therefore, this BCR-ABL technique is very important in patient uh, management process, right? Right. Next, very common question, very popular question. What is the difference between CML and leukomoid reaction? Okay. CML, now you know that's a malignant disorder, or that's a blood cancer. But leukomoid reaction, that's a benign response. Benign response means that is not a cancer, that is not a abnormal proliferation. That's a benign response to infection or inflammation, right? Or stress conditions, right? Then that's a immune reaction, actually. That is not the cancer. That's a benign response. You have to say that's a benign response, that's not the cancer, right? That is not a malignant disorder, leukomoid reaction, right? Then when considered the CML, that's a chronic disease, but leukomoid reaction, acute or sudden onset disease, right? That's recently that's happening within a few short time period, right? But CML will be developed during more and more time, right? Very slowly it will go, right? Then in CML, WBC count is very high, that may be more than 100,000, right? Then, but in leukomet reaction, usually it may be less than 50,000 WBC, right? that can be changed, but usually that is less than 50,000 WBC count, right? Then in CML, you can see full spectrum of myeloid maturation, as I told previously, blast cells less than 10%, promyelocyte, myelocyte, metamyelocyte, and all other matured cells with the NRBC. That is called as full spectrum of myeloid maturation. You can observe in CML. But in leukocyte reaction, mature neutrophils with few myeloid precursors, example myelocytes, and occasionally blast cells may or may not present in leukocyte reaction, right? And CML, again, eosinophil and basophil usually increase, but in leukocyte reaction, usually normal or low, right? Eosinophil and basophil count normal or low, right? In CML, your NAP score low or zero. In leukocyte reaction, your NAP score is high, right? Then in CML, your BCR-ABL quantification or the qualitative test positive, and leukocyte reaction, your BCR-ABL negative. By using this, you can nicely differentiate CML and leukocyte reaction, right? Okay, that's about the chronic myeloid leukemia or CGL or CML. Let's we move to the chronic lymphocytic leukemia. This also plays a major role, especially in leukemic cases, right? This affects 60 to 80 year old people, right? Mainly incidentally diagnosed when high WBC is detected in routine examination. The only problem, the main problem is here, right? When you go to the full blood count analysis, sometimes this CLL may be mislead with viral infection, right? Because in this type of full blood count reports, you can see slightly elevated WBC count sometimes, right, with normal hemoglobin, with normal platelet, but lymphocytosis, lymphocytes count is high continuously. Gradually lymphocyte increases. Usually when you go through this blood picture, you can see some uh, reactive types of lymphocytes. Then that is normally gives some evidences for the type of viral infection. But if the patient shows some continuous lymphocytosis with the increase of WBC count, when you go through the blood picture, if you're observing some more amount of lymphocytes with some smudge cells, definitely you should go through the blood smear very carefully. That may be evidence that those are maybe the evidences for CLL, right? Okay. Then you can see lymphadenopathy, right? Hepatosplenomegaly. Then symptoms are fever, night sweat, weight loss, extreme fatigue, then autoimmune hemolytic anemia, you can see in those type of patients, right? And leukopenia, thrombocytopenia, those are common features of chronic lymphocytic leukemia. Then investigations are again absolute lymphocyte count is greater than 5 into 10 to the power 9, right? In the majority, 30 to 300, right? That may be vary from 30 to 300,000, right? Then that may be that is finally WBC count increased, right? Then 70 to 99% of circulating WBC are mature lymphocytes, not lymphoblasts. Those are mature lymphocytes, right? Later, normocytic normochromic anemia, then thrombocytopenia may be. Uh, Thrombocytopenia you can not, when you can observe, you can identify thrombocytopenia in these type of CLL cases, right? Then this is the blood picture of CLL. Now, as I told previously, you can see this. These are mature lymphocytes here. These are somewhat reactive looking, but you can see mature lymphocytes are there. Then I told about some smudge cells. You can see these smudge cells, right? These are broken. When we draw the blood smear, these lymphocytes will be broken due to the fragility, right? These lymphocytes are very fragile, especially in CLL cases. These lymphocytes are somewhat fragile lymphocytes. When you draw the blood smear, then that lymphocytes will be smudged. Smudge means break. Cytoplasm, you can't identify a cytoplasm here. Only the nucleus. And diffuse means the smudged nucleus. You can see those are called as smudge cells. If you're having high WBC count with lymphocytosis with smudge cells, definitely you will be narrowed down into the CLL, right? Then when there is a question, write the blood morphological features of the blood smear features in CLL, you have to say increased lymphocyte or high lymphocyte count or lymphocytosis with high white blood cell count with smudge cells. You can identify the smudge cells in the blood picture. You must mention about the smudge cells in CLL, right? Except of that, you can say hyperchromic RBCs are there, then the RBC count is low. Like that, you can describe your blood picture in your answer. All right. Then diagnosis again, full blood count first, and then blood picture, smudge cells, mature lymphocytes, and sometimes because of the autoimmune hemolytic anemia, you can see RBC agglutination in that blood smear, right? Then peripheral blood flow cytometry we can do as further identification technique, right? Then bone marrow aspiration and refined biopsy as previous, then cytogenetic studies, right? Then this is the refined picture of CLL case, right? Then, as we know, normally with the bone marrow aspiration, they do refine biopsy and send to the histology lab. Then again send back to the hematology section to observe this refine. Right here, you can see a lot of lymphocytes. Right. Then other test. What are the other tests you can do to identify the CLL, LDH, serum LDH, electrolytes, liver and renal function test, uric acid, and the identification techniques for the autoimmune hemolytic anemia. Those are supportive tests for identify the CLL, not to identify actually to confirm the CLL, right? Because obviously we know with these leukemias, right, splenomegaly, hepatomegaly, right, a lot of renal function disorders will occur. As a result of that, this LFT and RFT will be obviously become abnormal, right? Then management, usually you can watch and wait early stages, and chemotherapy. They follow chemotherapy in chronic worst stages, right? Then here lymphadenopathy, you can see this type of lymph nodes enlargement in the CLA, right? Right, that's about the CLA, right? Now that's about the leukemia classification and the more details about the leukemia. But I need to discuss few details about the multiple myeloma too, because there may be a question related with the uh, serum protein electrophoresis, and or there may be a question related with some ESR, right? ESR and West-John protein, and related questions may be with the multiple myeloma. Therefore, I need to say something about the multiple myeloma. What is multiple myeloma? Proliferation of neoplastic plasma cells in your bone marrow. That's mean in your bone marrow, plasma cells, unwanted proliferation of plasma cells in bone marrow is the unwanted proliferation of plasma cells is the multiple myeloma, right? Plasma cells proliferate in bone marrow unwantedly. Then that secretes unwanted amount of immunoglobulin because of the plasma cells, right? Then immunoglobulins are proteins, gamma proteins. Then when you go through your uh, normal protein analysis, you can see low amount of albumin and globulin amount increase, right? Then if you're having high ESR, right, if the patient's blood smear shows roller formations in the blood smear and some plasma cells in the blood smear, then those are giving some evidences for the multiple myeloma. And when the patient's urine shows Benzoin protein positive and creatinine level high, and roller formation in the blood smear and plasma cells in the blood smear, then your protein level increased but albumin low, globulin increased, then definitely you have to do a serum protein electrophoresis. Then you can see the typical pattern for the electrophoresis. Right? We will discuss signs and symptoms: back pain, anemia, leukopenia, then renal failure, right? Investigations are for the multiple myeloma also, right? Full blood count, blood picture, ESR. In full blood count, you can see increased white blood cell count. And when you go to the blood smear, there may be plasma cells present in your blood smear. In the blood picture, then ESR become most of the time will become more than 100. Then serum protein, then albumin reduces, globulin increases. Then serum protein electrophoresis, urine based on protein may be positive, mainly positive in this case, right? Uh, then investigations in myeloma, uh, we can discuss under a few categories. Screening tests are full blood count, ESR, and X-rays, right? And protein electrophoresis, calcium and albumin. Diagnostic tests are bone marrow aspiration and refined biopsy. Then plasma cell phenotyping, immunofixation of serum and urine, then skeletal survey, right? Serum-free light chain assay, right? Those are the diagnostic tests in multiple myeloma. Then test done to estimate the tumor burden and prognosis. We can use FISH, fluorescence in situ hybridization technique, right? Then a test to assess full blood count, renal function test, creatinine clearance. Those are the tests that used to assess the multiple myeloma. Then special tests are MRI and CT scan, right? Those are some investigation module, right? Investigation module in multiple myeloma, right? Then in full blood count, as I told previously, anemia, that means low hemoglobin. Then other cytopenias less frequently. In blood picture, you can see ruler formation with some plasma cells. You must remember, even one plasma cells should not present in your blood, peripheral blood smear, right? If you observe, if you can identify even one plasma cells, definitely you should focus to this blood smear and you should follow the case, right? Then ESR is high, right? Serum albumin low, albumin globulin ratio reverse, right? Then serum calcium is high. This is the blood picture of the multiple myeloma case. Now you can see this ruler formation very nicely, and it will once you did your Leishman staining or Romanowski stain, you can see somewhat bluish color background because of the high protein amount that present in the myeloma blood, right? Then you can see somewhat bluish color background, right? Then ruler formation you can observe. Then you can identify some plasma cells present there. This is not clear. I will show you. Now here, this is a clear picture. You see a lot of plasma cells present. Now, what are the features of plasma cell? This is a plasma cell. You can see eccentric nucleus here. In theory, in books they says, right? In the books that says cartwheel appearance you can observe in the nucleus, but actually cartwheel appearance you can't observe. But you can see some perforated nucleus here. That nucleus indented to one side, and your cytoplasm is somewhat larger, right? And dark blue cytoplasm, and cell is large, right? Eccentric nucleus you can see, and surround the nucleus you can see a clear zone that is called perinuclear halo. Perinuclear halo. In this cell, actually uh, previous. In this cell, you can identify some perinuclear halo. Here, large cell, nuclear, eccentric nucleus, and cytoplasm, dark blue cytoplasm, and perinuclear halo present. Then this type of cell is we called as plasma cell. What is the difference between this plasma cell and NRBC? NRBC, then NRBC also shows some eccentric nucleus and shows perinuclear halo, but that size is equal to the RBC, and that cytoplasm color is equal to the RBC cytoplasmic color. Therefore, you should not mislead an NRBC with the plasma cell. There may be some small plasma cells present in your blood picture, but you will never mislead the plasma cells with the NRBC because NRBC cytoplasm is color is totally equal to the cytoplasm of the red blood cell. Can you hear me well? Another?
Yes.
Right. Okay, then serum protein electrophoresis pattern, as I told previously, you will receive a low albumin peak and gamma globulin band here. Then this is the typical protein electrophoresis pattern in the case of the multiple myeloma, right? And these are radiological findings in multiple myeloma. You can see some METs, right? Calcified bone or calcium deposits, right? And fractures in the vertebral column, right? Wedge fractures, right? Because these with the multiple myeloma, your bone, that patient's bone will become somewhat perforated, right? Correlated. And treatments are thalidomide, lenalidomide, lot of treatments techniques, right? Present they used in multiple myeloma cases. Okay, right. Then specimen samples that can be used to do the flow cytometry. This is also important to give answer for maybe important for answer for the question. Other specimens that can use to do flow cytometry, peripheral blood you can use, bone marrow aspirate you can use, then CSF, cerebrospinal fluid, and some peritoneal fluid, pleural fluid, and uh, tissues. Actually, when you consider the tissues, you should have the extract of the tissue to do this flow cytometry. Those are some specimens used in flow cytometry. This is flow cytometry technique principle, right? Flow cytometry is the last technique, confirmatory technique to classify or identify the leukemia types with the help of cytogenetic studies. Right. That's the end of my presentation. Right now, this is the time to do a small discussion or to discuss the questions related with this and related with the general hematology. Right, Dinesh? Feel free to ask the questions. ප්‍රශ්න තියෙනවා නම් අහන්න ඩිස්කස් කරන්න පුළුවන්. මම හිතනවා අයිඩියා එකක් ගත්තා කියලා මේ presentation එකෙන් leukemia ගැන. Right. Now this is the time to ask questions. Right.
මම දැන් කට්ටියට දැන් අන්මියුට් කරන්න පුළුවන්. You can unmute your mic.
ඕන ප්‍රශ්නයක් මේකට රිලේටඩ් වෙච්ච ප්‍රශ්නයක් අහන්න පුළුවන්. එහෙම නැත්නම් hematology වල general hematology වල ඒවා අහන්න පුළුවන්. මම හිතන්නේ ඉස්සරහට lecture එකක් තියෙයි, discussion එකක් තියෙයි general hematology වල. අපිට questions කීපයක් paper එකට එන නිසා ඒවා මතක් කරගන්නත් එක්ක ඕන එකක් අහන්න පුළුවන්. Feel free to ask the questions. Before that, now, sorry, give me another 2 minutes, right? Now you can give the answers for this question. This question came, I normally taken from a past paper, right? The patient has a full blood count reported with total WBC. This is high WBC count. Write down 3 possible errors that can be occurred in the process of automatic full blood count analysis. That is, they asking about the analytical errors there, right? Analytical errors, right? That what are the possible, what may be possible errors in full blood count analysis. Then they expecting false increase or false decrease results. What are the reasons for false increase or false decrease result? Here, mainly false increase results, false elevated results can be seen in full blood count analysis mainly due to NRBC, present of NRBC in the blood, right? That gives false increase results. We know that in modern analysis that NRBC normally corrected and giving some corrected WBC count with the high developed technology, because they have we use some NRBC dye there. Then separately we can count NRBC. We can have the NRBC count, and normally analyzer automatically gives corrected WBC. But if you don't have that type of analyzer, definitely you will be receive false increased WBC count. Then you have to draw a blood smear, and you should count separately the NRBC percentage, and you should do the WBC correction for that. That's a one possible error, right? Because of the presence of the WBC. Another possible error is having some minor or the partially clotted blood smear, right? Partially minor clots present in blood also gives some wrong results. And another one is sample collected from drip arm or diluted blood. Sample collected from drip arm. That's also gives you results in analyzer. And another one is partially aspirated blood in the analysis process. Sometimes your analyzer may aspirated blood partially, right? Partial, we call it as partial aspiration. Due to the partial aspiration, your WBC count may be falsely decreased. Another thing is air bubbles present in the blood. If your analyzer aspirated some air bubbles with the blood, again it will give false low results for the WBC count. Those are some important points that I need to mention the blood. In the second question, the blood picture of above sample showed very high neutrophil count with less shift. Name 2 probable clinical conditions. Now, what is the answer? That may be due to the CML or leukomoid reaction. Those are the 2 probable conditions: chronic myelocytic leukemia or leukomoid reaction. List 4 blood morphological features supports to differentiate about 2 clinical conditions. Now you can do that very nicely. In CML, you can consider about, you can give the answer about the granulocytic precursor cells, blast cells present, then promyelocyte present, myelocyte present, metamyelocyte present in the CML, right? And mature neutrophil lymphocytes, eosinophils, maybe not maybe, neutrophil is present, basophils present, right? Those are the morphological features. They just asking for blood morphological features. Then in leukomoid reaction, you have mature neutrophils and uh, uh, few amount of myeloid precursors, example myelocytes, and few blast cells may or may not present. That is the answer for that question, right? Okay, now you can give the answers for these type of questions, I hope. Okay, now you can ask the questions.
Guru, some have asked the question at the chat box.
Yes. One person going to ask a question, but we can't hear you clearly.
Isru, can you see your chat box? I think there is some question.
Right. There are questions, right? Right. Let's see the right. There's one thing. Can we see smudge cells with normal WBC count? Yes, can. We can see some smudge cells because of the physical destruction, right? Then you can see smudge cells with the white blood normal WBC count, but with the high WBC count, if you see a lot of smudge cells with the high WBC count, it may be due to the CLL. But if you noticed any type of any amount of smudge cells in your blood smear, you should carefully go through the blood smear to omit the CLL. The question.